All right, everyone. Thanks for joining us. Welcome to the Q&A session for musculoskeletal oral presentations. I'm Matt Buckner. I'll be moderating the session with our panelists. Really exciting set of abstracts that were submitted here. Great projects that I think are really pushing the envelope in terms of what focused ultrasound is capable of, thinking about the musculoskeletal perspective. So let's just jump right in with our panelists. Now, Harshni Ashar, I was hoping we could start with you and your really exciting study. It was a basic science study looking at how to potentially treat osteomyelitis with focused ultrasound and antibiotic-laden thermally sensitive liposomes. And I was wondering, it seems like you were able to achieve quite a dramatic increase in the concentration of antibiotic along the bone implant interface. But do you think that it might be possible to go even further than what you were able to achieve?
Hello, Matt. Really excited to be here. So yes, that is essentially like a long-term goal that we are looking at and trying to achieve, which is better targeting and more drug delivery compared to what we currently have. So since this was a pilot study with a very small set of animals, we believe by using different nanoparticles like magnetic nanoparticles, etc., we can better localize the nanoparticles in the area of region of interest and have better drug delivery.
That's great. Here's a question from our audience. Obviously, biofilms can be a real challenge in the setting of hardware that's implanted, these colonies that are very resistant to antibiotic penetration. Were you able to detect whether or not your approach was able to destroy biofilms in any way?
Yes. So essentially what we looked at in this set of animal studies is the biofilm load on the implanted metal wires, as well as the bacterial load within the bone. And we found that we had greater bacterial killing on the implanted wires compared to the bone itself. So I think the answer to the question is yes, we did see greater bactericidal effects in relation to biofilm.
Yeah, that's great. I think, as you alluded to in your abstract, many of these really intractable infections can require prolonged courses of therapy. Do you think you would envision this approach as something that you would want to repeat several times in the course of a patient's antibiotic regimen, or do you think just a couple of sessions? What sort of temporal requirements do you think there would be?
So that is a great question, and essentially, ideally, the goal would be to decrease the number of treatments and the frequency of treatments, to make it clinically relevant. And since, as I mentioned earlier, this is a pilot study, and since a biofilm infection can be so complex and it involves multiple variables and factors. Essentially, I'm sorry, I lost my train of thought. So yes, so we do need to see whether we can make this clinically relevant in terms of having, maybe 2 or 3 treatment rather than prolonged treatments.
Yeah, it seems like that would be an interesting follow-up study to see if you did it 1 time or 2 times or 3 times, what is the result after a week or so, something like that. Maybe you're already thinking along those lines.
Yes.
Maybe one more question before we shift to another topic. Did the artifact associated with the K-wires, did that pose any challenges for your technique in terms of visualization at all, or that wasn't was that not an issue?
Since we've used ultrasound guided treatment, that wasn't really considered in this study.
Yeah. Okay, that makes sense. All right. Well, thank you so much for that really interesting, exciting study. Dr. Joe Ball, can we maybe shift to you? And you had a really interesting study, full disclosure, I should admit, of which I'm a co-author, a pooled meta-analysis of 33 studies with 1,082 patients looking at focused ultrasound treatments for painful bone metastases. And the first, maybe the first question I wanted to ask is, did you see a dominant tumor type across the studies that you looked at all? Was there any, obviously there are certain cancer types that are more likely to go to bone. So I didn't know if you saw that reflected across the studies at all.
Okay, first off, thanks Matt for having me. Great question. So so we expect certain cancer types to metastasize to the bone more than other cancer types. And we did see this distribution reflected in our data set. So the predominant cancer types were breast, which was, I think, about 30% of our study population, and followed by prostate, renal cell, and lung, which is within what we expected.
Yeah, that sounds pretty similar to sort of real world experience. And then a follow-up, it did seem like, as expected, the frequency of grade 3 type toxicity was pretty rare. I think you mentioned there were maybe a handful of instances where some patients had fractures associated with the treatment. And even though that's rare, I don't know if it was clear at all from those studies if there was a certain type of bone that was more affected than other bones.
Sure, and that's also another good question. Unfortunately, the studies that looked into the adverse events didn't provide granular data about the types of bones that were fractured. And so we couldn't go into further sub-analyses to answer that type of question. But in terms of the types of bones that were outlined, our data set were predominantly, interestingly, within the pelvis. So it could be that our data set may be a bit skewed to that type of bone, which opens up other questions in the future as to how different types of bone react to HIFU treatment.
Yeah, no, that makes a lot of sense. Thank you. And then maybe we can shift gears. I think there's a nice connection between your work and work of Alessandro Di Maio, I believe is coming to us from La Sapienza. So really exciting to see focused ultrasound and radiation therapy because you sort of put head to head in a randomized controlled trial. I think that this might be one of the first trials of to really tackle this important question. And maybe I can follow up first with a related question, what I asked Joe Alessandro, which is, did you have any sense that there were differences in the types of tumors between the two groups in terms of breast cancer, lung cancer, any differences like that between the groups?
First of all, hi everyone, and thank you for the opportunity. Let's say that more or less, as we were saying, also the same prevalences of types of cancers and the sites, we also saw a similar pattern. Precisely, we had sort of 35% of cancers, especially in the pelvis, and those were also the most accessible ones, considering also all the possible side effects from an intervention on a spine. And so those were the primary ones. And also, what was also interesting to see is also some also at the ribs as a part of the superficial bones, and also around 10%, especially involvement of the upper and lower limbs, which always happens. Instead, for the primary tumor, again, prostate cancer, we had around a 37%, if I recall correctly. And then again, breast cancer was the second most common, and then lung. This more or less a similar population, and in fact, we could see some similarities with the work.
Yeah, that makes sense. It's very similar to the typical patient population with bone metastases. A follow-up there, some of these metastases can have very different appearances on the MRI. Prostate cancer often is very sclerotic and very dense, whereas breast cancer is more often lytic and will destroy bone. Do you have a sense that different types of metastases respond differently to focused ultrasound, or does your group, do you have different approaches when you see different kinds of metastases?
Okay. First of all, there is to say that in general, here the goal was to treat the pain. So especially if the surface was not eroded, the main goal was just to do a periosteal denervation. And if instead, as it was more common, especially for some breast cancers, as I think it could be interesting also to do a specific sub-analysis and see if some specific tumors responded better than other ones. For example, yes, this could be quite interesting. And what I was thinking is also that in some other studies, especially some prostate cancer, we saw some sort of in other study they defined it as tumor control. So that when we treat for the tumor, especially if it has an eroded surface, and we go even beyond the surface, we can have some reduction in size. And also, sometimes we notice with the increased survival, and also that some patient has some sort of an abscopal effect. So with exposure of the metastasis and some antigens, somehow, so that's why also another study is going for this, and so also see if by treating the metastasis, we can trace back and treat even the primary tumor. That could be interesting.
Yeah, that's really fascinating concept. Here's one question from the audience: whether or not you could try to describe if was the focused ultrasound typically performed in one session, or did some patients have multiple focused ultrasound treatments? And do you know how many sessions of radiation did the patients with radiation have? Was it one single session, or is it multifractionated?
Okay, so let's say our main role was, first of all, for the focused ultrasound, we only used one session. So just to see, especially to confirm previous studies, but also to see the difference with the radiation therapy, in which most of the cases with the aid of radiotherapists, they also aimed for a single dose, eight single sessions, so for radiotherapy, while around 20% they performed the 10 fractionations one, but this was especially up to the radiotherapist.
Got it. So I want to, I feel like one of the most interesting results is the difference in survival between the groups. And I know you mentioned the potential of an abscopal type effect. Is that what you think is behind the improved survival, or what do you have a sense, or is it maybe patients are using less pain medication and therefore having less issues related to that? What do you think is driving that?
Honestly, yeah, I think it's especially also as we saw some differences, especially with the typical sensations of radiotherapy, like nausea, changes in appetite, dyspnea. And so those were ranked way, way lower in the focused ultrasound group. And maybe we attained a significant 1.38 times more likely for survival in a patient. So for longer survival for a patient treated with focused ultrasound. And this maybe is also with the quality of life, which was perceived a bit better. But let's see, hopefully also some trypsy or other studies may be useful for this.
Yeah, that was a really exciting result. So looking forward to seeing more follow-up work from you and your group. And now maybe we'll shift gears again to a study by William Chu Kwan. Really exciting, totally novel indication for focused ultrasound, partially ablating tendons in the setting of, for example, patient contractures. Sometimes patients have chronic illnesses that can sort of limit their mobility and hold their tendons in specific patterns. And so it's necessary to try to disrupt that. William, there were a couple of starter, fairly technical questions from the audience. Maybe we can start with those. The first is, were you able to monitor cavitation from boiling histiotripsy from the 3 different peak pressures?
So basically in our study per se, we did not monitor the cavitation. However, our group had already done previous studies where we used the same parameters, and we were able to actually calculate the negative pressure that would induce a cavitation. And it's based on those parameters that we decided to apply them to our current treatment. But at the current time, we're not monitoring yet, but it is something that we're considering to monitor cavitation during treatment, because that way we'll be able to better know that the cavitation is happening. And once cavitation is induced, then we can start with the ablation on top of it and just like take advantage of the cavitation bubble to actually produce more localized ablation without harming the tissue surrounding any other structure.
Yeah, that makes a lot of sense. That's great. Another question here. Do you have a sense of the time lag between boiling histiotripsy and sort of, I guess, completion of ablation?
So basically, we did some of the preliminary work that we didn't publish in here, but it actually informed us on the sequence of events and the timing between histotripsy and ablation. And we did find out that if we do histotripsy and waited too long, all the effect of histotripsy, or most of the effect of histotripsy, was not harvested for the ablation. And we saw that if we waited too long, the effects of ablation were about the same as the effect of doing ablation alone versus doing histotripsy or ablation. So sometimes when as in our feasibility study, we're even like doing like MRI scans in between treatments, and we found out that the optimal sequence was histotripsy with immediate within 5 seconds.
Got it. Interesting, very interesting. I wonder if, for context for our audience who might be less familiar with the challenge of dealing with patients who might suffer from contractures in clinics, do you have a sense of, are there other non-surgical approaches that are used to disrupt tendons in practice? I know certainly there are surgical approaches, but.
Right. So basically, we have what we call a lot of preventative and possibly palliative treatments. So when a patient comes in with a contracture, and I work at the hospital of sick children or sick kids, so we deal with a lot of kids with cerebral palsy and neuromuscular diseases. So the first thing we do is that at the onset of contracture, we try to splint them. But splinting, it's only effective, according to the literature and from our practice, they have to be splinted for 22 hours a day, which I was like, what? Don't you just say 24 hours, right? Yeah. Less than 22 is not really effective. So the side effects of splinting is basically it creates a lot of pressure ulcers, and that is something we want to avoid. Apart from that, there's a lot of physiotherapy, but physiotherapy is really costly, and it's painful to the patients. They're literally just pushing them to the limit, and those are the main 2 things. And we also use a antispasmodic medication like baclofen, where we just inject it to the patients, and it just avoids them to be too contracted. But these are more palliations because once the contracture has already happened, the final treatment and definitive treatment is surgery. And unfortunately, one of the side effects of surgery is recurrence of the disease. So these are kids that come to the OR year after year, scar after scar. And this is mainly contracture. However, if I just want to go a little bit further, there's a lot of surgeries that we do where we cut people's tendon, and some of the other indications are like toe walking in pediatrics, or even diabetic ulcer redefinition of people's gait. So when someone with a ulcer due to diabetes, they always have a pressure ulcer at that spot. So what we do is just we go in and actually slice their Achilles tendon in order to balance their gait. So these are some of the indications for either contracture or tendon resections.
Well, thank you so much for that background and for exploring this really exciting new indication for focused ultrasound.
Thank you.
I want to thank all the presenters here for doing this really exciting work and for joining me in this panel session so we could talk